And go ahead.
All right, so Dr. Witcraft and I are going to be talking with you all a little bit about stress in pregnancy and postpartum this afternoon. Next slide, please. We have no financial disclosures to report. Next slide. So our goals for today is to give a very brief background of stress and cortisol and some of the ways in which this changes in pregnancy. Give a brief overview of the fields, including some of the current barriers in terms of understanding this approach. Introduce resiliency and why that's important, and then we'll transition to some of the overlap between anxiety and stress and treatment considerations. We're hoping that you'll be able to identify at least one skill that you can teach to your patients to better cope with stress after today's talk. Next slide. So, just a brief overview. Stress is really common, as you all probably can imagine. 2 in 5 people in the US experience a stressful life event in the year leading up to pregnancy. We're probably all familiar with this statistic, but 20% of folks experience a mental health condition during that prenatal period, so pregnancy and the immediate postpartum period. And as we all know, folks who experience stress in pregnancy are at a greater risk for some of those mental health outcomes and also some more negative birth and maternal outcomes. And so there is a theoretical pathway. There are a few actually of them that have been proposed for the role that, uh, there you go. The role that stress plays in terms of the pathways through some of these outcomes. And we could probably spend over an hour just talking about some of these and really going down into a rabbit hole. So my goal today is to kind of give a good overview of some of that and some of the data that's been looked at in some of the larger reviews that have been more recently published. So if you go to the next slide, we will see the autonomic nervous system. And you all are probably familiar with this. So we have the sympathetic and the parasympathetic nervous system. And when we as humans experience and encounter a stressor, one of these systems gets activated and the other one gets turned off. So the fight or flight response gets activated. We get ready to run away from a stressor or a tiger, maybe for the example. And all of the kind of non-essential functions get turned off through that process. And so when we think about kind of the immediate stress response, this is a symptom that we're thinking of. It is a pretty short-term system. There's a ton of energy that our bodies require to be able to be in the fight or flight response. And our sympathetic nervous system turns off. Usually it's about like 30 minutes. There's not like a hard cutoff, but it can't be activated for that long. It's that really fast short-term response. If you go to the next slide, we start to see what access and what mechanisms are responsible for more longer term stress. So when we are in a situation or a stressor that's more prolonged, a different system becomes activated and involved, and it's related more to the endocrine system and background. And so you all might be familiar with the HPA axis, but for the sake of this talk, the end result is cortisol is excreted. And cortisol is a negative feedback loop in response to, or cortisol is a hormone that's secreted in response to stress. So if you go to the next slide, you'll see that the diurnal cortisol kind of chart that we look at. So cortisol naturally is going to fluctuate through our bodies throughout the day. So about 30 to 45 minutes after we wake up, we have this peak in cortisol. It should be the highest level that we experience throughout the day. And then as the day progresses into nighttime, our cortisol levels start going down and dropping into a trough. And then that peak returns the next morning. And it's important to note that cortisol is pretty strongly influenced by things like the time of day that we're eating. Of course, when we wake up, there are a number of factors that influence cortisol production. And there are a few different types of cortisol that's actually produced by the body. And this is important when we're thinking about measurement and looking at outcomes. Um, so What I think is pretty cool. A lot of cool things happen during pregnancy, but the changes that we see in the HPA axis in pregnancy, I think, are pretty remarkable. So the placenta, when it's formed, actually changes the that negative feedback loop of cortisol into a positive feedback loop. And so essentially, what that means is that as your pregnancy progresses, people's bodies are going to have a lot more cortisol, nearly 3 times throughout the duration towards the end of pregnancy. And after delivery, within a week of delivery, our bodies return back to those pre-pregnancy levels of cortisol. So this is a pretty kind of rapid, in terms of like the entire lifespan change that we experience throughout our pregnancy. And so, if you go to the next slide, there's just a little kind of visual of what that looks like. The more science-minded folks probably can look at this a little bit more efficiently than I can, but it's just to demonstrate the changes in terms of how the placenta functions. Notably, cortisol can get to the fetus. It can cross that barrier. And so there have been a number of studies, especially more recently, looking at the role of stress and especially cortisol, and trying to understand how that impacts outcomes. So I'll share with you some of that, a kind of a brief overview. But before we go there, if you go to the next slide, I think it's also important to note that there are a number of different ways that we measure stress, and it's notable that there's no universally agreed upon definition of what stress is. When folks are seeing a tiger, when you see a tiger, your body has the same response to that tiger as it does to giving a talk. Or having if you're afraid of heights and you are going bungee jumping. So that stress response is the same. And it could be anxiety or stress. And there are different words to describe that subjective experience. But internally, what's happening in your body, there's kind of no definition that's agreed upon for that. There's a lot of variability in stress, and partially because there's no universally agreed upon definition. So when we're thinking about those biological samples, looking at cortisol levels, we can use um, salivatory samples to do this. And as I mentioned earlier, your cortisol is going to fluctuate throughout the day based on what you're eating, kind of your sleep patterns. So looking at this on average is recommended to be the most helpful, or trying to be super consistent and scheduled. We can also look at that through hair, and that looks at more of a kind of a broader scope of cortisol levels. We also have self-report measures of stress. There's just the perceived stress scale. That's a pretty commonly used one. Again, it's how somebody is appraising their experience. You all are probably familiar with the ACEs, or different measures of social determinants of health, and kind of adding those up. We also have stressful life events and daily hassles, and something that might be stressful for me might not actually be stressful for you. There's also the emotional state. So looking at kind of state versus trait responses to stress and anxiety, because those terms can be used interchangeably when we're thinking about biologically what's happening in the body. There is also some disagreement about when is the optimal way to be measuring stress, especially when we're thinking about the prenatal and postpartum period. Is it actually in childhood, so maternal childhood? Is it preconception? Is it throughout pregnancy, postpartum? All of these kind of measurement considerations are really important when we're actually looking at the data and the outcomes. It's important to note that there are changes in when we're thinking about acute versus chronic stressor exposures, how that influences our bodies over time. Is it stress or is it mental health? And then knowing about the role of race and discrimination and chronic exposure to discrimination and how that impacts that chronic stress experience. All of these are really, really important factors. And I raise these before even going into any of the outcomes, because I think that there is so much stigma potentially that can happen when we're thinking about stress in pregnancy and postpartum. And I think that many folks can feel can really internalize like shame and blame for experiencing stress if now they're kind of receiving information that this could potentially influence their pregnancy outcomes. When in fact, if they experience stress in childhood, did they really have much control over that experience? And so I think that all of these things are just kind of important to raise your awareness to when we're talking about this topic. So if we go to the next slide, um, the state of the literature is very mixed when we're thinking about the impacts of stress exposure in pregnancy and postpartum. I will make the argument that you can probably find at least one publication to support your argument in terms of is stress bad, is it good, negative effects, no effects. But overall, what we've started looking at, or the field has started looking at, are more of these scoping reviews. And in a large scoping review published in 2023, the consistent finding was that maternal childhood stress was found to be impacting cortisol the most. And all of the other studies found kind of essentially null associations, really inconsistent findings, inconsistent directions. And that's why I say you could probably find a study to support your argument in when it comes to stress, which is just leads us to believe that some of those measurement errors and also more attention to this is probably warranted. Um, I think if we're taking kind of that theoretical approach, um, we also have to think about risk and protective factors. So the life course approach is one of those kind of theories and really looks at the role of different protective factors over the lifespan in response to particularly chronic stressors. So if you click one more time, this is just the review. It's a very, if you're interested in this topic, I highly recommend taking a read at this one because it goes really deep into the science and into the outcomes. But summarized here that there are very mixed. So next, if we kind of shift gears and look more at the social sciences literature in pregnancy and postpartum, there are a lot of unrealistic norms and expectations around pregnancy and postpartum and what that experience might look like. There's a lot of variability in terms of social support, having access to kind of variable healthcare experiences, positive or negative. And there are a number of concerns about potentially health outcomes. And all of these things can experience or influence the experience of stress in pregnancy and postpartum and anxiety. Again, remember there's that strong overlap between the two. One of the big reviews that I was reading in this literature really, I think, highlighted this pretty well that the socially constructed ideas of motherhood and all of those unrealistic expectations in pregnancy can lead to potentially anxiety and stress if there's that discrepancy between expectations and outcomes experiences. And so I think that this can really drive kind of that appraisal again of what a stressor is. Something that's stressful for me might not be stressful for you. Consistent with pretty much all of the stress literature, especially the chronic stress exposure, social support during this time was identified as a really, really important factor to mitigate some of the impacts of stress. Notably, male partners also do experience distress during this time. And so, even though somebody is partnered or has a family system or is reporting friends, that doesn't inherently mean that they have social support. So, it's not just the presence, physical presence of someone, but kind of the quality of the support that they're providing. Notably, women felt less supported in in postpartum than in pregnancy, which is something that I think we see clinically pretty often, especially as the postpartum period kind of goes on and this expectation of like, okay, my village, where did they go? Everybody or people were coming and checking on me when I first got home, but now it's been 4 months and I haven't slept in 4 months and I really could use some support. Um, it's also notable, given some of the maternal morbidity and mortality outcomes, just to appreciate that negative experiences of the healthcare system have also been found to predict some of those stress outcomes. So I think that this is still my section. So kind of highlighting what we've been talking about so far, all of the complex mechanisms that are impacting that role of stress throughout somebody's life, including in pregnancy, the resiliency that somebody may or may not have access to, which is positively associated with pregnancy outcomes. So, resiliency can be achieved through social support. It can also be achieved through a number of different kind of coping responses to stress. And also the appraisal of stress, how somebody views an event as being stressful or not. So, if you're thinking about this in context of your patients, making sure that you're screening for stress in pregnancy in a way that might help identify who could potentially benefit from increasing some of these supports to try to mitigate any impacts to the stress exposure. Um, Again, I included this last line here that some of the theories and kind of approaches, even for well-meaning providers, can inadvertently increase shame and blame or perpetuate stigma that a patient might be experiencing. And so, again, it's important to remember just because something might be stressful for you does not mean that it's necessarily perceived or appraised as stressful for someone else. So, really trying to think of folks in almost like a straight-spaced approach. How are they viewing this situation? What supports can we increase and build upon to help mitigate any of those potentially negative impacts of stress? And also, kind of bearing in mind that some of those stress outcomes are from stress that the mother was exposed to in her childhood. And so, being really mindful that there are a number of factors that potentially could be at play, whether it's historical or even current, that that person might not really have a whole lot of control over. And so the good news, though, is that there are some things that we can do, including in pregnancy and postpartum. Next slide.
Okay. Thanks, Dr. Hayes. That was a great overview of stress and pregnancy. I'm going to talk a little bit about, mostly about some tools that we can use with our patients to help decrease stress. Before I get to that, I wanted to talk a little bit, kind of extending what Dr. Hayes was just talking about, some of the research on the effects of physiological arousal in pregnancy. So, a lot of people, patients will have this idea, at least anecdotally, that they don't want to increase their stress or do things to get really active because they're afraid of what that might do to the baby. So, presenting some research here on this is mostly exposure therapy and kind of intentional physiological arousal. So just really quickly, this isn't super relevant to the rest of the talk, but exposure therapy, for those of you who aren't familiar, it's the gold standard treatment for anxiety. And it's the intentional and gradual exposure to feared stimuli. So for people, for example, who have panic disorder, who are really afraid of their own internal experiences, increased heart rate, and things like that, we would actually bring on those physiological sensations that they're afraid of. To help them understand that one, this is not dangerous. When your heart races, it doesn't mean you're having a heart attack. And two, to learn that they can tolerate those sensations. So there are a few contraindications to exposure therapy listed here. Vast majority of people in the general population, this is totally safe to do. And notably, there's not a ton of research on exposure therapy in pregnant people because of some of these misunderstandings and excluding pregnant individuals from research trials. But the research that we do have indicates that this is a really acceptable approach to treating anxiety and stress during pregnancy. Pregnant people are totally fine to do this. In non-pregnant people, exposure therapy, kind of contrary to what people believe, it really only moderately increases heart rate for a short period of time. So we're talking maximum 130 beats per minute, which is followed by rapid habitual physiological habituation. So that increase in heart rate and other physiological indicators of stress decrease pretty quickly during that exposure. And this is important to know. ACOG doesn't have, it used to be kind of 140 beats per minute is where we want to cap, for example, exercise. And that's not necessarily the guidelines anymore, but just for reference, we're below that with exposure therapy. So totally safe for the vast majority of individuals. Patients, contrary to what is kind of held in popular belief that exposure therapy is really intense emotionally and physically, patients are really only reporting a moderate amount of anxiety and distress. So it's really both subjectively and objectively stress-wise, not as intense as some people are believe. And then during pregnancy, there is, as Dr. Hayes mentioned, there's kind of some mixed evidence on the effects of stress during pregnancy, but there are some studies to indicate that during laboratory stressors, so doing kind of bringing pregnant people into the lab and having them do certain activities to increase their stress or their physiological stress response, there's actually a dampened physiological arousal, so lower heart rate and blood pressure and things like that, which is contrary to what most people would expect when engaging in those types of activities. So we follow similar guidelines with these types of treatments as ACOG recommends for exercise. So there are some contraindications for certain conditions during pregnancy, high-risk pregnancies, placenta previa, things like that, that we wouldn't necessarily recommend intense exercise in. So we kind of follow those same guidelines here. If you go to the next slide, I'll talk about not necessarily exposure, but some interventions that we can do with folks who are experiencing a high level of stress during pregnancy and also outside of pregnancy. For those who, again, are reporting a high level of stress. So if someone's coming to your office and fills out a GAD-7 and the anxiety score is really high, or they're reporting that they're experiencing a lot of stress, these are just some tools. There's many others out there, but these are some evidence-based tools that we can use with these folks. So the first is mindfulness. So mindfulness, it's kind of a hot topic in pop psychology right now. But what we mean when we talk about mindfulness is the intentional paying attention in the present moment on purpose and non-judgmentally. So not judging our internal experience or kind of our external circumstances, just accepting it for what it is in that moment. So this is the opposite of avoiding or suppressing thoughts, feelings, emotions, memories, physiological sensations, any of those experiences that are considered uncomfortable or aversive. So we're really, instead of suppressing those, we're really just kind of holding them lightly and allowing them to be there again without judgment. So there's this statement, if you aren't willing to have it, you will. So this idea that if we try to suppress something or pretend that we're not having a hard time, it's likely to kind of come back up and usually does so more intensely. So we really want to try to help folks not to avoid those internal experiences that are uncomfortable. And mindfulness is one way that we can do that. So there's a lot of different ways to practice mindfulness. It's not necessarily this idea that I'm going to sit down and just kind of zen out, not think about anything, clear my mind. That is really not what we're doing when we're practicing mindfulness. Instead, what we're doing is really just allowing the present experience to be what it is. So, noticing thoughts that are coming into your head and not pushing them away, but just kind of acknowledging that they're there, not grabbing onto them and really analyzing what does this mean and kind of digging into it, but just again holding it lightly and kind of letting them pass naturally. So again, lots of different ways to incorporate mindfulness into daily practice. I mean, you really, the great thing about mindfulness is you can do anything mindfully. You don't necessarily have to carve out a separate protected time to practice mindfulness, although that can be helpful for certain folks to kind of put that on the radar, schedule it to make sure that they remember to do it. But really, we can practice mindfulness with something as simple as our breath. So just kind of sitting or laying or whatever position is comfortable, closing your eyes and really turning inward and just noticing the natural rhythm of the breath. While that's happening, we're noticing if thoughts are coming into our head. And again, we're not clinging on to them or pushing them away, but rather just noticing that they're there and recentering on the breath. We can practice mindfulness with eating, mindful eating, kind of noticing the textures, the flavor, the smell, just kind of the whole experience rather than, scarfing some food down while you're scrolling through TikTok or whatever. So really being present in that moment and noticing all the different elements of the food or whatever the person's doing. Going for walks and exercise is also a great way to practice mindfulness, particularly on a nice day like this. If we're walking outside, just hearing the sounds, seeing, the surrounding areas, hearing what's going on around us. So really, everything can be done with mindfulness. Yoga and mindful meditation are some more formal practices of mindfulness that some people really enjoy having that kind of carved out with that kind of mind-body connection. And then finally, there's a lot of apps. If you're really not sure where to begin with mindfulness and how to instruct patients how to use it, there's apps like Headspace, Calm, Insight Timer is at least in part free. So those are some options that you can recommend, and there's many more that can, and also YouTube is a great resource. Having people Google things and look on YouTube, there's a lot of stuff there. Um, so the next skill is distress tolerance skills. And so what distress tolerance is, broadly speaking, is it's somebody's perceived capability to tolerate distress, and that can be physiological distress, it can be emotional distress. And it's also the behavioral act of withstanding distressing internal states. So it's kind of a multifaceted concept, but really to kind of summarize it, it's somebody's perceived ability to withstand aversive emotional states and physical states. So people that have low distress tolerance, meaning that they don't perceive that they have the ability to withstand stress, tend to adapt or tend to maladaptively respond to distress in a really rigid way. So this tends to look like a lot of avoidance. Every time a stressful situation comes up, they're kind of responding to it in an avoidant way instead of approaching it more flexibly with different options. Maybe instead of avoiding it or pushing it away, they'll just continue to do what they're doing or engage in a more approach-oriented behavior, which is what we see with folks that have high tolerance to stress. Um, and what the thing to keep in mind with distress tolerance in particular is this is a skill that's really better suited for short-term use. It is not something that we want to approach with chronic stressors, but really if there's a really high level of stress, very overwhelming amount of emotions, this is where distress tolerance would be useful. So if we go to the next slide, I'll talk. This is kind of 4-in-1 skills actually, but this is taken from DBT distress tolerance. Sorry, I'm seeing Rachel is texting me.
Yeah, hi, Dr. Witcraft. Just I wanted to say I think this would be a good place to break so that we can do a brief Q&A and then we can return to this in the case.
Okay,
Just because
whatever.
we're over time right now, so I wanted to give participants a chance to ask questions and engage with one another briefly.
Okay, yeah, yeah, that's fine.
Okay, thanks. One sec.